afternoon, we'll be talking about cardiovascular diseases in pregnancy. It's a very, very important topic. As you all know, I'm sure there are some of us here that are pregnant. And, okay, I can see some of my people here. So there are some of our women here that are pregnant. And for the husbands of such women, you are also pregnant husbands. So this is very, very important. Okay, so I have no disclosures. This is going to be my outline. And it's important for us to understand that cardiovascular diseases is the leading cause of maternal morbidity and mortality all over the world. And that spectrum, of CVD in pregnancy is changing for many reasons. I'm going to be telling us some of the reasons why it's changing. And what you see also depend on the regions of the world. You see, as much as 4% of pregnancies may even have cardiovascular complications, even though they did not have a prior cardiovascular disease. And then it's important for us to understand that wherever you are, home or abroad, the most frequent cardiovascular disease in pregnancy are hypertensive disorders of pregnancy. Okay? And I'm sure that a lot of us see this on a daily basis. So, but there are some disparities, with respect to patterns. For example, in the Western world, they see more of congenital heart diseases. Okay? And one of the reasons is because these days, treatment of congenital heart disease have improved so much, that many people are living longer. Okay? And because of that, they are able to exercise the right to get pregnant. In this part of the world, rheumatic valvular disease, they predominate, and Nigeria has a peculiarity. And the peculiarity for Nigeria is that we have the highest burden of peripartum cardiomyopathy all over the world, okay? Such that it has an incidence of as high as 1 in 96 deliveries. And mortality at 1 year, approaches 50%. So we'll be talking more about this shortly. So this is the spectrum of cardiovascular disease that you may see in pregnancy: hypertension, congenital disease, valvular disease, either rheumatic or non-rheumatic. For example, if you're talking about mitral valve prolapse, which is quite common in some parts of the world, arrhythmias like supraventricular tachycardia or atrial fibrillation. So we just finished talking about stroke. Stroke is also on the list. So what are the risk factors for cardiovascular diseases in pregnancy? One, increasing age. These days, some women, maybe not much in this part of the world, but women are deferring, starting a family, okay? And of course, we also have high levels of infertility, preventing women from getting pregnant early on in their reproductive career. So because of that can predispose patients to cardiovascular disease. And with increasing age comes cardiovascular risk factors like obesity, hypertension, diabetes mellitus. We've been talking about some of these things. So they can predispose patients to cardiovascular disease. I've talked about improved treatment of congenital heart diseases, autoimmune diseases like SLE. We know that the female to male ratio for SLE is about 13:1. It can be as high as 13:1. So women with SLE, when they get pregnant, are at an increased risk of developing cardiovascular disease. There are also nulliparity, multiparity, multifetal pregnancies, long interpregnancy interval, and then IVF, which is quite common these days because of ovarian hyperstimulation and maternal intolerance, autoimmune intolerance. This can make pregnant women to have increased risk of cardiovascular disease. With respect to pathophysiology, now, pregnancy can mimic cardiovascular disease. And the reason for that is because of the physiological changes in pregnancy. These changes in the first trimester, they increase in the first trimester, peak in the second, and then they can plateau on the third. And they all mark the most important thing, pathophysiological change during pregnancy in the first trimester is an increase in cardiac output. And that increase can be as much as 50%, okay? With an increase in blood volume. By the second trimester, that change may peak. In the third trimester, because of a gravid uterus, it can compress on the vena cava and reduce cardiac output. But after delivery, the cardiac output, blood pressure, they go back up again. So because of this tremendous increase in plasma volume during pregnancy, you may see pregnant women and it will seem to you as if they have cardiovascular disease. Also, because of this increase, pregnant women with poor cardiac reserve, so somebody who has a cardiovascular disease, can easily be tipped over to a complication, maybe somebody who has valvular heart disease, he's been stable, he gets pregnant, that patient or that woman, pregnant woman, is a candidate for heart failure decompensation. Okay. Now, and that takes us to clinical presentation. I said that some of these physiological changes can mimic pregnancy. So at times it can be difficult to sort out, the wheat from the chaff, okay? And so a careful history and thorough physical examination is very, very imperative. For example now, pregnant women, normal pregnancy can cause difficulty with breathing on exertion. It can also cause leg swelling. Abi? So when you see that, you may start thinking, oh, this patient may have cardiovascular disease. And in fact, they may not. So dyspnea on exertion, leg swelling are common things that you can see during pregnancy. It doesn't mean that the patient has a cardiovascular disease. And it does not mean that the patient does not have cardiovascular disease. But there are some other symptoms that you see that are red flags. So if someone now presents with orthopnea, paroxysmal nocturnal dyspnea, has angina, those ones, they are no-go areas, they are red flags. What you should do, I know that most of us are family physicians, GPs, I know there are some specialists amongst us too. What you should do is to refer for specialist care. We'll be talking a bit more about that later. So for patients too, their blood pressure must be measured. Of course, in pregnancy, pregnancy can cause physiological murmurs. So in which case the murmurs are soft, they are usually mid-systolic, and you hear them at the left sternal, lower sternal edge. Any other thing outside that may be pathological, okay? So for such patients, you should refer them for specialist care. If you are not sure, even cardiologists, they debate amongst themselves. They fight. No, this is diastolic. No, this is systolic. If you are not sure, just refer for specialist care. Now, urinalysis is also very, very important for proteinuria. For all pregnant women with cardiac disease or cardiovascular disease, they must all have pre-pregnancy counseling. And at times, it starts from their last pregnancy. So somebody has just delivered, has peripartal cardiomyopathy, you should do counseling for such patients. Okay, so all pregnant women with cardiovascular disease must have pre-pregnancy counseling. Why? So that they can know what the risk, the maternal risk is, what the fetal risk is. Then, so that you can outline a plan for how the pregnancy will go, how they are going to be delivered, and the things that you're going to do. So another important thing that must be done for this group of patients is that you must assess their risk, maternal risk. I said you have to assess maternal risk. Just like as Dr. Salah was talking about risk for cardiovascular disease. So in pregnant women with cardiovascular disease, you must assess what the risk is, how bad it is. So one important tool that we use is the modified World Health Organization assessment tool. So you're going to be seeing that shortly. There are other assessment tools, but I'll show this one very soon. So there are some other specialist evaluations that you may have to do. ECG, basic, echocardiography, preferred imaging modality in pregnancy, because you will not be exposing your patients to what? To what? Irradiation, okay? Like in X-ray. The others you may have to do, the others are not in the purview of let me say, of general physicians. Okay, so these are in the purview of specialists. Okay? So I don't want us to waste a lot of time discussing them. So this is the WHO maternal risk assessment tool. It divides into 5 groups, 1 to 4. So, and you have the diagnosis, so it tells you what the diagnosis is, okay, what the maternal event rate, cardiac rate is. As we said, all pregnant women with cardiovascular disease must have counseling. Then, where they should get care for that pregnancy. Okay, should it be at the local hospital or at a referral hospital? What sort of follow-up you should do? Should you follow up once or twice or so, and then the location of delivery? So all of this, so the point is that for patients with WHO class of 2 to 4, you must refer them for specialist care. And what it's what encompasses, or the point for referral is because you want to do what you call the cardio-obstetrics team model, in which you have the cardiologist, the obstetrician, and other specialties, working, having a plan for preconception, for pregnancy, for labor, for delivery, and for postpartum care, for that patient. So these are not groups of patients that the GP, for example, can see, Patients like this must always be referred. So when you refer patients with cardiovascular disease, when you suspect that a patient may have cardiovascular disease, so there's a new symptom or sign, an unexplained symptom or sign, or somebody comes and says, I have heart failure and I'm pregnant. Okay, so such patients should be referred for specialist care. So we're just briefly going to look at some of the conditions, the cardiovascular diseases, and see what you should do when you come in contact with patients like this. So we know that hypertension in pregnancy is when blood pressure is persistently elevated above 140, when it is 140/90 and above. Is that right? Okay, so, but it is severe when it is 1/60/110 and above. And it is an emergency if it is 170/110 and above. Okay, so you can also classify hypertension in pregnancy into those 4 groups. Chronic hypertension, that's if the hypertension was there before 20 weeks. Gestation, gestational, if you diagnose it after 20 weeks. If there's proteinuria and there's maternal organ dysfunction, maybe AKI, acute kidney injury, liver problems, convulsion, platelet abnormalities, then you can say the patient has preeclampsia. Otherwise, it's just transient hypertension, because you expect that blood pressure to resolve within 6 weeks after delivery. Now, the 2 of them can, coexist, and you can have antenatally unclassified. Say you are seeing a patient for the first time, 20 weeks gestation, and you're not sure whether it was there before, or it's a new thing. So what do you do for patients who are present to you with hypertension in pregnancy? If a patient comes, no blood pressure, then all you need to do is to reassess them at every visit. Is that okay? But if the blood pressure is above 140/90, but not severe, so these are the guideline, first-line recommended medications that you can use: oral labetalol, methyl dopa, and extended-release nifedipine. And you want to target a blood pressure of just less than 140/90. Is that okay? Now, if it is severe, 160/110 and above, then that's an obstetrical emergency. So those are the groups of patients that you should refer. If you're worried about referring without doing anything, get specialist help. I'm sure if you call Dr. Iseko, he's going to answer you. Abi, Dr. Iseko, you are going to answer them. And for such, for the benefit of the residents that may be here, what you do in that scenario is that you give IV labetalol, like Dr. Mimi said, 10 to 20 milligrams over 1 to 2 minutes. Okay, there are other things that you can use, and you just want to lower to less than 160/105 over 2 to 3 hours. Now, if someone has preeclampsia, then of course, or eclampsia, you can add magnesium sulfate. For those patients, I always tell the obstetricians in my hospital, it is not every severe hypertension that you give labetalol to. If the patient has heart failure or pulmonary edema, don't give them labetalol because of the risk of cardiogenic shock. In that case, you do intravenous nitroglycerin infusion. Or if you have a tablet or you have a spray, you can also do that. Now, for heart failure, so let me skip this. Just to...
So in short, before they give IV labetalol, you must listen to the chest.
Yes, you must listen to the chest. The patient must not be in heart failure. Because if the patient is in heart failure and you give labetalol,
the patient will not survive.
He won't survive. So
the blood pressure is 170, 110, 180, 120. Don't just rush. Take your stethoscope, listen to the chest. You are sure you are not hearing crepitations like bubbles all over the place. If you are hearing that the blood pressure is very high, you give IV labetalol, you will never forget. And that will not be for a good reason.
Yeah, you will always remember, all your life. So please don't do that. Now, again, to emphasize on my point that patients with cardiovascular disease in pregnancy should be referred. You must get specialist help. Look at this example. This 32-year-old woman, hypertensive, had dyspnea 7 weeks after a CS, went to the GP, ordered for an echo, ordered for NT-proBNP, and then decided to put her on furosemide and spironolactone. And the patient didn't come to see the cardiologist until 6 months after because a relation of hers just asked her, have you seen the cardiologist? Said no. So, but when she saw the cardiologist, you can see the array of medications that the cardiologist put the patient on. And this is very important because peripartal cardiomyopathy is one of the reversible causes of heart failure. Heart failure is a progressive disease, but there are some causes of heart failure that can be reversed. Peripartum cardiomyopathy is one of them. And that's why you must send them to the specialist very early on. Okay. Now, to answer the question, the person who asked the question the other time. So during pregnancy, some of those medications we use for heart failure are not compatible, so you may have to alter them. That's why you need to send to the specialist. So typically you can use hydrolyzing with nitrates, but postpartum, if the patient would elect not to breastfeed, you can put them on all the normal medications that we use for heart failure.
Sorry, that hydrolyzing is not IV.
It's oral, please. It's oral. And it's usually in a combination, hydrolyzing plus nitrates. Anyway, you are not expected to use this. You see somebody who you suspect has heart failure or has heart failure, send for specialist care. Okay, so for stroke, I'm not going to say so much about stroke because Dr. Mimi has done justice to that. So I will just move on. This was a 33-year-old patient of mine who had mitral valve replacement, then got pregnant when she had been told not to get pregnant, and then came to clinic and we placed her on enoxaparin. And then because of cost, decided to be using it daily instead of twice daily. Then 4 weeks later, developed a stroke and came with it. We did a scan. In fact, in the internal capsule, she made full recovery. So very, very important. So let's just move on. Now, I also want to emphasize on this. Very, very important. PE is common in pregnancy. So now, I'll illustrate it with 2 examples. One of my patients, 38-year-old seizure disorder patient, at TGA 16 weeks, was crossing a culvert, fell, broke her ankle, and then went to the GP. So the GP claimed that she declined anticoagulation, but she Okay, let me move.
See, you are looking at it will be clear tomorrow.
Okay.
Hopefully.
Okay. So let's move on. Now, MI can happen in pregnancy. So any pregnant woman has chest pain, they must have two things, ECG and troponin. You can't do that, just refer. After you've done those two, also refer. You know, because they can have what we call spontaneous coronary artery dissection, which is the commonest cause of myocardial infarction in pregnant women. Very important. Well, pulmonary hypertension and ischemia, I'm rounding up now. This is just to exemplify one of those conditions in which patients should be discouraged from getting pregnant. You know, because the mortality, fetal and both maternal, is more than 50%. You know, so there are certain conditions, cardiovascular conditions, that you must discourage the women from getting pregnant. So with respect to the delivery, it should be vaginal for most patients for most pregnant women with cardiovascular disease. You should only do CS for obstetric reasons. Now, this is the other one that we should also watch out for. Before you give any pregnant woman any drug, you must check for the clinical safety data. Very, very important, okay? So that you don't go and give tetracycline to a pregnant woman or something like that, okay? So in summary, I'm through now. I will leave now, okay? So in summary, what I want us to take away is that one, cardiovascular disease in pregnancy, they are the leading cause of maternal morbidity and mortality. We should not forget that. Two, when you suspect that a pregnant woman has cardiovascular disease or there's an established cardiovascular disease, please get specialist help. Thank you.
Please, a round of applause.